this week on the BackTable podcast.
So all of us do that. All of us develop new techniques. On the device side, a lot of it just came from being in a hospital of last resort and having the ball, as it were, and being responsible for finding a solution and feeling that responsibility deeply. And we all have that, right? And there's a key element in our profession of that. When you see people limited by billing codes or by FDA approval, I don't know. I think that just really pisses me off. They're usually golfers. And I don't hire golfers because they're not working at weekends. They're in that stupid game. And so my favorite people to hire are helicopter pilots because they're really good with their hands and their feet. And they can think and do all sorts of things at one time.
Today we have another special episode discussing a recent book released by Dr. Kieran Murphy titled Essence of Invention, Medicine and the Joy of Creativity. Dr. Murphy is a well-known figure in the field of neurointerventional radiology, interventional radiology, and medical innovation. He's contributed significantly to the development of new technologies, new techniques, and devices in medicine, including the Murphy needle for vertebral augmentation. Dr. Murphy, welcome to the show.
Thanks. Thank you so much. You're very, very kind to contact me and do this.
Yeah. And, now after reading your book, and I apologize, I know I was supposed to have you on earlier. I am a slow reader, but it is a lot of great stories in this book, and we're going to pull out a few teasers. But I now know a fair amount about you after reading your book. But for the uninitiated, can you just tell our audience a little bit about where you're at and what your practice looks like? Because I know you're still practicing.
Yeah, so I'm an interventional neuroradiologist. I primarily do spine now. Apparently I saw over 1,000 patients last year, treated about 600. We have a really, really busy practice here in Toronto at the University of Toronto Western Hospital, the largest neuroscience centre in Canada. I've been here for 15 years. For the 10 years before that, I was head of neurointervention at Hopkins. I was on call for the vast majority of that, and 10 years of 1 and 2 or 1 and 1 call. And we moved here because I was kind of burnt out and tired of treating horrible things in East Baltimore. So I developed devices, but that comes from the fact that I never say no. And so somebody will ask me to do something, and I'll go, okay. And then I wind up waking up at 2 a.m. going, why didn't I say no? Like, what the hell was I thinking? And that's where the techniques or the devices come from, right? So as a group, we invent both techniques and devices. And the devices tend to get the focus, but I've had huge fun developing things like transcranial Doppler with ultrasound contrast. That was great, because suddenly you get color, or gadolinium enhanced MRA of the carotids, which Jim Meany and I did on each other at the University of Michigan with Martin Prince in the background. And that was all fun until I had an allergic reaction to some horrible new contrast, and we stopped that then. And then the CT stuff is brilliant. The building 320 slice CT with Toshiba was great fun. And CT fluoro is still, I think, one of the best tools I have. It's a fantastic tool. There's more creativity in those areas, I think, in many ways than there is on the diagnostic side, right? I mean, the diagnostic side is industry limited, but on the vascular imaging side and the guidance side, there's lots of fun to have. And that's separate from devices. So all of us do that. All of us develop new techniques. On the device side, a lot of it just came from being in a hospital of last resort and having the ball, as it were, and being responsible for finding a solution and feeling that responsibility deeply. And we all have that, right? And there's a key element in our profession of that. When you see people limited by billing codes or by FDA approval, I don't know. I think that just really pisses me off. They're usually golfers. And I don't hire golfers because they're not working at weekends. They're in that stupid game. And so my favorite people to hire are helicopter pilots because they're really good with their hands and their feet. And they can think and do all sorts of things at one time. So ex-military helicopter pilots who went through ROTC, they're great fellows,
Oh, I bet.
Yeah.
No, I mean, the creativity piece is what gravitated me towards IR as well. And I'm sure most of our audience sitting in front of the screen and reading CT after CT, there is less creativity in that. I mean, not to discourage people from going into diagnostic radiology, I just feel like every procedure you do, there's opportunity to come up with a new technique, to come up with something creative that makes that procedure even faster or even more effective. And we hear it all the time on this podcast where we bring somebody on and we talk about something even as basic as placing a Mediport or doing a bone marrow biopsy. You learn something from somebody else on how to do that procedure better, how to get a better biopsy, those sorts of things. And so that's why I gravitated towards IRs. Is you're right, there is a lot of room for creativity and improvement.
Yeah, I think there's also tremendous simple joy in doing any procedure well. It could just be drawing blood, could be placing an IV. There's craft in that. And we're really craftsmen. I have more in common with the guys in the blue shirts in the basement of our hospital than I do my diagnostic colleagues. You know, the people who are the plumbers and the masons and the electricians, and I know a lot of them, and I'm proud of knowing them. And they know my name, and we have a lot in common. We're there at all sorts of weird hours of days and nights, and we're not reading from home or reading MRIs from our cottage or something else. We're actually on site all the time, providing service.
Yeah. And you get that face-to-face, and you get that gratification, that instant gratification when a procedure goes well, a patient gets better. They say thank you, even though a lot of times they don't know, again, who you are or what what your specialty is. They do appreciate the things we do. And every time you treat a patient, they learn who IR is, what we do. That is the other kind of neat thing about it.
I've had a lot of procedures personally, right? I over the last couple of years, I have 7 coronary stents now and an aortic valve replacement and a chronic autoimmune disease. So like 3 weeks ago, I had paroxysmal AFib after eating a popsicle. And the cold of the popsicle triggered my left atrium to go into a hypotensive, low cardiac output state with angina, go to the hospital, wind up in the ICU. And you are dependent on the people around you to look after you, right? And their competence. And there are people who can command a room and exude confidence when they come in. And that person has a thing. They have competence, they have skill, they figure this out, they know what they're doing, and they're usually happy. So a young lady walked into the room when I was about to get a TEE and cardioversion, and it was funny. You look at her and think, this woman is competent. And it's an energy we exude where we know what we're doing.
Right.
And that's a huge piece of what we do in our field. Say something simple. Somebody's been struggling to do an LP, and you walk in the room, you talk to the patient, and you reassure them, and you do it, and you leave. And the patient knows that a craftsman has done something. So we're craftsmen in the same way that many professions are. And it's an essential piece of how hospitals function. And we do it with our hands and eyes and our cerebellums and our coordination. And I think it's a beautiful thing. We're very, very lucky.
That is true. It's your icky guy, right? You've heard that term before.
Yeah, I know that book. Yeah. I'm familiar with that. It is a Zen state. If you look around this library, you'll find
I see a lot of books.
A lot of books in Tibetan. I speak Tibetan. And I've worked with Tibetan refugees for 40 years. And now they have WhatsApp. They use a lot of happy emojis. I get ridiculous. But there is a spirit in what we do. And do you remember Zen of the Art of Motorcycle Maintenance?
Yes, I know the book, yeah.
You got to read it. It's all about the joy of having a craft and quality. What is quality? We know when we see it. We know when we experience it. We have a very hard time describing what it is. And that's the beauty of our profession, I think. Whether it be cardiologists, vascular surgeons, interventional radiologists, interventional neuroradiologists, we do simple things or complex things with quality and control.
Yeah, and you cover these topics a lot in this book, and I wanted to, this is a huge topic, innovation, innovators in medicine. You really capture a lot of the history of medicine and surgery and IR in this book. What inspired you to tackle the topic, and how did you get started with researching this book?
So one of the reasons I wanted to do this is I think it's very poorly understood. And every boring administrator on the planet talks about innovation, like it's something you can Just open a bottle and there it is. But really, you need to hire innovative people or creative people, and it's about the inventors, not the word innovation. If you don't have inventors in your community, you're not going to have innovation. And we have too few inventors, and they need mentorship, they need a little bit of space. Sometimes there are management problems, they may be difficult even, but they bring a key energy that changes the society around them, rather like the photoelectric effect. When that electron leaves that shell, goes up, goes somewhere new, comes back, spreads that energy around the shell it was in before. So I wanted to study this, and it began when I realized there was kind of a tribal difference between proceduralists and diagnosticians in radiology at Hopkins, just a very different tribal culture. And that goes back to, the Germans and the Austrians, Erich Fromm and Freud and everyone else, and tribal differences in groups. But I wanted to have data instead of just opinions. So I was running the annual SIOR meeting in Tampa, 2010. I spent a year before it, the entire membership of the SIOR cross-referenced their names, nearly 6,000 of them, with patent filings at the USPTO and PCT. And I identified the 447 patent holders. Then we contacted them and built social network maps of them. You could see at the time, key people built communities around them, like Stanley Baum and Stan Cope at UPenn. And those places were more likely to take foreign medical graduates. You could track people as they moved. Scott Terratola leaves one place, moves to another place. Suddenly there's innovation there. Then he leaves and goes somewhere else. Then it happens there. It's clearly about individuals, but the institution has to provide the right milieu, the right environment, the right conditions. So then we repeated that project just in 2019 because I wanted to do it in this cohort over 10 years, because none of these Malcolm Gladwell types have that kind of information. They just tell stories about people. They're not actually creative themselves. They're not. If you look at what they do, they're just telling about other people's lives. Isaacson writing about Musk is just being a diarist. He's being a biographer. He's not creative, right? And we differ from the guys like Gates and Musk, etc., because we are socially functional. We're not creative sociopaths. We're empathetic, compassionate people. And we're very different human beings, and yet we're inventive and creative. In fact, we're probably in the normal range of personality types in terms of our social functionality. And they're not the people that get written about. So the SIR cohort of inventors is unique. So when I went back after 10 years, what I found was the people who were inventive in 2009 are still inventive in 2019. There's no relationship to age. Like if you're funny you're funny throughout your whole life. If you're not funny, you're not going to be funny. And it is related to inventorship too. I think humor and inventorship are related. Key locations. The peak inventorship occurs during fellowship. That's the moment where folks who have an inkling they want to do something different can begin to express it. If they leave their fellowship program and move to a small community hospital somewhere, it's pretty much over, because then they don't have the social network to commercialize their idea. When they try and tell the local Boston Scientific sales rep, hey, I came up with this thing, the best that sales rep can do is talk to his area manager, who probably doesn't know the engineers and whose metric for success is their quarterly sales. If they're at UPenn and they express it to an engineer who's there for a clinical trial that they're doing of their new device, then it can filter into the right pathway to get listened to within Boston Scientific. So the rate of either getting a patent or not successfully getting a patent for folks who are in community practice is much, much lower than if you're at UPenn, Hopkins, Stanford, UCLA, UCSF, the usual suspects. So that milieu is critical, not only for the mentorship and support at the beginning, but for finding a pathway into industry who can make your idea with you.
Yeah. I mean, that was one of my favorite chapters in this book, was in what environments do inventors flourish? And like you said, it's about the people around you and the surroundings. You're right. When you think about the people who have invented Julio Palmas and Barry Yoshida and these guys, and you mentioned a lot of people from Penn also throughout the book, it does tend to be, academic centers where you have those resources and you have those people that you can run those things by. It's few and far between that it's just a high volume community practice doc. I would agree with that.
It isn't exclusive. There'll be guys like Craig of the Craig Needle, etc., who will pull this off, but they're already established.
Right.
Have you ever been to Greece with those monasteries on the tops of mountains that are like stalagmites?
I haven't. No.
Okay, so they remind me of academic centers in a way. So they're kind of monastic. You go there, you're focused, you're probably not financially driven. Your goals, missions, objectives are set by the institution. The dean and the CEO may be one person. There's an alignment, flux constantly of bright minds wanting to work with you, who keep you on your toes. Nobody has a job for life. In a lot of socialized systems, people have jobs for life. That's a terrible thing. That breeds mediocrity. We have that here in Canada. I can't think of any context in which I would get fired unless I did something awful that deserved to get fired for. At Hopkins, the turnover is there because it's a bit like J&J. The bottom 10% get fired every year.
Well, that's also a good way to get rid of mediocrity, right? So,
yes, and you have to
average it out.
Because that's how you create jobs for younger faculty.
Yeah, exactly. There's a couple other teasers that I really like. They were my favorite parts of the book. One is, the section 4, you start out, page 154. You talk about the journey from idea to clinical adoption is like surfing. And this resonated with me because I just told you, Kieran, I just moved to San Diego. So, we got in the summer, and I've tried surfing before, but I'm like, I'm going to give a real shot at it, right? And so what you're describing in those 3 paragraphs is exactly what I went through over the summer, where, your kids are on the beach and you're out there giving it your all, and it's a beat down. It's real, really. But you catch that one wave and you ride it in, and that's enough to get you hooked. And you may, like you said, you may not want to do it again, but a month later, you're like, you remember that feeling. But elaborate on that.
Well, first of all, I'm a really crap surfer. I have not managed to stand up on a board all over the place. And one of our jobs as being a dad is to amuse our children and fail, right? And they need to see us fail too. It's really important that they don't think that everything we do works. But I love trying to surf, and it's the same when I race cars. I crash less, but a lot less.
That's higher stakes, I would say.
It is. But it's the same kind of thing. I think people underestimate how difficult it is to have your idea turned into a product. I mean, my ozone device, it's 20 years now. When I had, that idea of making a simpler device, I'd seen Mario Muto speak at a meeting, and I spent the 8-hour flight back to Washington doodling and drawing the device on the airplane. There's 2 important messages there. Going to meetings is important because random conversations happen that don't happen over Skype or Teams. Human interaction, humans require face-to-face meetings. Huge tradition in medicine of traveling to learn. And it's really elemental to how we share knowledge and gain knowledge. Second thing is isolation. Being isolated on an airplane is one of the few places I can actually be alone. And they give you a glass of wine, there are some nuts, maybe some food, you sit there, you doodle, you think, and you have enough time to nuance an idea. Like, I love flying to Australia because it's 14 hours of thinking time.
And your phone's off, there's no distractions.
Yeah, and you're guilt-free.
That's true.
You're going away. It's different when you're coming back, because then you're full of dread and pessimism about how bad the accumulated work's going to be. But like with the ozone thing, false starts. We tried really hard, we failed. Another company tried really hard, they failed. I managed to bring the 2 companies together, build a new company. We have raised our B round. We have $8 million in the bank. We've got a great engineering team. We're at CE in Europe and Health Canada. We're doing cases here under special access, a particular pathway in Health Canada. There is this anxiety you have as an inventor when your device is used clinically that is unique. I'm confident in my needles now because they've been used a couple of million times. I'm confident in the cements and the injectors, the DuraJect injector, the biopsy systems. I'm proud of them. because it's a couple of million people who benefited from those things. The ozone thing, I spend a huge amount of time thinking this is still mad. And because you got a gas, O3, dissolving a nucleus pulposus and shrinking it, not like a grape to a raisin, but just enough to decrease the pressure on the adjacent nerve roots. All of these things begin as a thought experiment. That's what I believe it's called. But most of all, it's sort of a reverie. And many different people have used that same technique. All humans have it. We used to call it daydreaming, right? Einstein would hold a spoon in his hand and have a plate under it, and he would sit in a chair and he would doze, and if he fell asleep, the spoon would drop, hit the plate, and he would wake up and he would record his thoughts. I do it with a mug of coffee in the morning with the dog. Yeah, I get the dog up. The dog gets me up at 6. I have about an hour of essentially meditation every morning, and I think about these kind of problems. But we need that reflective time to do it.
Absolutely. And the other example you brought up in the book that again resonates with me is the shower time, right? Where again, you have this white noise and you don't have, again, any distractions or phone. You're going through the motions of soaping down your body, but your mind is going, and some great ideas happen in the shower. And you describe this in the book as well.
Yeah. And I think one of the great examples is Colin Chapman designing race cars by lying in the bath and realizing, this is really low. If I put a steering wheel over my belly button and the engine behind me, we could go faster. That kind of thinking, that kind of synapse cannot be explained, can only be experienced. Paul McCartney does this. Niels Bohr did this. Schrodinger did this. It's a common human technique. And it's a bit like wit, right? When you make a funny comment at the right time, and often you don't even know what you're going to say until you say it. But it has developed in your pre-verbalization world in your head, and then goes to Wernicke's area, and then goes to Broca's area. As soon as it hit Wernicke, you know what it is, and it's out. But it happened before you were even conscious of it. I think that's fascinating.
Yeah, there's a spontaneous element to it, right? You can't plan it, really.
No, it's probably corpus callosal. And so one of the fun projects, I'm only going to write 2 more papers. I have no interest in, unless my students or fellows need it, I'm not going to bother. But one of them is going to be on the imaging of our inner voice. Where does it lie? So, the resting state network with fMRI shows as you need a whole brain, kind of a global soul, like Anton Damasio said. And you have this network with prioritization occurring in the precentral cortex. And if you don't prioritize, you have ADHD, right? You can't prioritize. If you do, you can search and mitigate and intertwine things. Now, we're just going to have fun with this. I have some donor dollars. We'll do magnetoencephalography, and a sort of a 3D MPR MRI of the brain, and then co-register them. And I'll have some Tibetans come meditate in the MRI and then in the mag. And then and you've got one of these at UC San Diego. I was in it years ago. And different people, and just do enjoyable things like localize the network of the inner voice. We all have words of reassurance when we're stressed. Some of us say prayers. I'd like to take people of different religious backgrounds and just see what happens when they repeat those words, whether they be Muslim or Jewish or Catholic or Lutheran or whatever. And I bet you it'll be the same place.
Activates the same place.
Yeah. And that sociologically is important. So that's the kind of stuff I want to do in the future. It's more difficult than making a better needle.
But
at the same time, it's fun, And so our
it's
research
fun and creative.
has to be fun.
Yeah.
So I think a lot of people don't understand that this stuff is fun. And if it's fun, it's not work. And if it's fun, there are no boundaries. It doesn't happen between 9 and 5. happens every day of the week.
Right. You're always thinking about it. Exactly. Well, speaking of something that I thought was fun that was in the book, tell us about formalin versus honey and amber, because I think that's really fascinating.
Yeah, that was cool. So I had a great student, Diana, and actually she's at UCSD doing some MR research and doing a PhD now. So I was really pissed off because I got a bunch of negative blastic bone vertebral body biopsies back from pathology, in a totally white vertebra on CT. I got a great chunk of bone on biplane fluoro guidance. It comes back negative. I was thinking, can't be negative. It's clearly prostate cancer. It can't be negative. So I repeated the biopsy. It was negative again. I just was pissed. So I had worked previously on increasing the yield of infection biopsies. And so I thought, okay, nobody makes liquids. I'm going to look at formalin and look at how it treats cells and see if it can do better. It's been around for 100 years. So I looked at the liquids used to transport lungs and kidneys. Thought, let's treat the biopsy specimen as if it's living and going to be implanted into somebody else. Okay? And then so that was easy because there's a ton of stuff around. There's something called Perfidex that's used for lungs. And then I thought, okay, how do we fix that? And then Diana and I came up with the idea of honey because it was used to embalm people in pyramids in Egypt and by the Romans. It doesn't go off. And it's used for wound healing in animals and all sorts of things. It's a very interesting material. It's the only food that doesn't go off. So turns out one of my donors is the largest honey importer into Canada. And his wife is even called Honey. But he imports shitloads of honey, like 40 containers a month. So he used Manuka honey. We've worked on this for 4 years. Formalin binds RNA and DNA and really impairs immunohistochemistry. If you have your biopsy done on a Friday and it's formalin fixed, the accuracy of your tissue diagnosis is worse on Monday than it would be if it was biopsied on Monday and processed during the week. So we always think pathology is definitive.
Right.
They don't cut the right slice. They're wrong.
Right.
And they can even misinterpret what they're looking at, right? So pathologists are no different than radiologists when it comes to error rates. So this liquid, we initially used animal tissue, mouse tissue, then human tissue. And we've been able to show that we can preserve tissue out to 7 days. And even tissue in paraffin blocks that have been embedded in amber can have RNA extracted from it at 7 days. So it's a huge breakthrough. The other thing about formalin is it's carcinogenic. So people who work in embalming, people who work in labs can get lung cancer. It has to be treated in a vacuum hood, managed in a vacuum hood. We spent about $11 million here on our pathology department just handling the air. So we can get rid of all of that. And now we're doing some fun stuff with Edwards Life Sciences, where they're going to use amber for their porcine heart experiments, looking at cardiac contractility with different kind of TAVI and valve implants. So it just came from irritation. I was unhappy at the standard. Pathologists are some of the least imaginative people in medicine, but they're pathologists. What do you expect? Lovely people. They roll around in dead stuff. So they're not like interventional radiologists. On the Myers-Briggs classification of humans, they are the most conservative ritualistic you could find, right? So they're not going to think of changing anything because they'd have to change their patterns. And they're all kind of little OCD, like dentists. But so this just came from irritation at the status quo.
Yeah,
and
frustration.
That's what drives most people to invent. It's not
but
good enough. We're going to do better.
Yeah, but you also have this background, you're well-educated historically, and so you were thinking about the preservative qualities of honey, and you had this, all the stars aligned, right? You had this friend who's a honey importer, and it all kind of came together in your brain, and I think that's where pattern recognition really is also a key part of being an inventor. Is just, okay, there's something here, there's something here, there's something here, let's put them all together. And it comes together as a solution to a frustration that you had.
You got to follow through too, right?
Yeah, execution is everything.
One of the key things is it's all great to have an idea, but most people don't bother following through. So I was fortunate. I have donor dollars. I probably over the last 2 years received about $6 million in donations from patients, and that gives me freedom. That, like at Hopkins, I didn't have that. I never had academic time in Hopkins, and for the last couple of years, since I got sick in August 16, 2016, which was a medical error, I've been fortunate that the donor support has enabled me to buy 2 research days a week from my group so that I can think. Now, that's a huge luxury, but it also means that I need $30,000 to fund a master's student to work on amber. Then we can do that, and then that student gets to do we looked at the imaging properties of amber in your MRI machines because we added 1% coconut oil to it to make it bright on T1. So then you could check margins around the tumor tissue, right? And see if the margins were clear, just thinking through how intelligently to handle tissue. So then you help people's careers and you build careers and you watch people flourish. And that's incredibly rewarding as well.
Absolutely. Absolutely. And so given everything that you've seen in your career, and you obviously researched a lot of inventors and innovators, and we just kind of talked a little bit about where docs maybe don't get it quite right in execution. Where do you think physician innovators and inventors get it? We talked a little bit about you got to have the right environment. We talked a little bit about execution, but where do you think docs get it wrong most often? Is it the 2 things we already mentioned?
I think small amounts of funding, really critical, $15,000, $20,000 to do something, not big things. We're not people who can write NIH grants. We're not professional grant writers. It's not going to happen. I think just small amounts of funding, working with the foundation of your hospital to work directly with the patients you treat to get small amounts of funding to fund the things you care about. Learning how to talk to wealthy patients to see if they're willing to support your program. We're really bad at that. The SIO should do something about that, and that's another thing they should work on. We treat so many people. Now, one of the joys of doing spine intervention is, I have so many patients who have donated to our research because I helped with their back pain. That never happened when I was coiling aneurysms or gluing AVMs or treating strokes. For a lot of my older patients, and a huge percentage of them are from the Jewish community who do this all the time, they give. They have a tradition of giving. You relieve somebody's facet pain or you treat their compression fracture. They get to stay in their home. They don't have to go into a nursing home. They get to be with their family. Our busiest time of the year is the week before Christmas, 2 weeks before Christmas, because a lot of our patients won't be here because of their metastatic disease. This will be their last Christmas, right? So we do these things. And sometimes it's, somebody in their 90s whose back is just shit. And the facets look like barnacles. And you do something really, really simple. You make them pain-free. And then 3 months later, you get a phone call saying, hey, Mr. Winberg just donated $100,000 to your research. And that's what keeps our program alive. Big, complex stuff. It's the simple, kind stuff. And it is strange when you change the relationship of, I'm just going to look after you and fix you, to, hey, could you support our program? But a lot of the people who give are already supporting other programs. And their family money is going into a foundation that supports maybe the oncology program or patient family respite space or something like that. And instead they're just going to give a small amount to you, but it makes a huge difference in buying you time to think, to create, to make a 3D printed model of something, to do a little animal work,
That's really interesting, Kieran, because you think of, now we hear a lot about private equity and VC and you think of fundraising in those terms, but you're right. I mean, you could just go to your patients who suffer from that problem and say, hey, look, I'm researching this. How do you set up a vehicle for that? Do you have a liaison that you introduce them to?
So most hospitals will have a foundation coordinator who raises money for the new dialysis machine or the new wing, or here, a $1.2 billion for a new surgical tower. And there'll be somebody appointed to radiology You just got to learn who that person is and meet with them, explain what you do. And then once you've identified a patient that has means to do this, then you just say to that patient, hey, look, everything's gone well. Would you like to talk to one of our people at the foundation who would help you help other patients? You can work on the language around how you express that yourself, but the patients I come across, they're wonderful who do this. All of my patients are wonderful. I'm very lucky. But the ones who donate are very generous and have supported our program for like 10 years now. It's made a huge, huge difference.
Well, that's great. That's actually solid advice for people who have ideas, and they're dedicated to execution, like we said, is essential, but just need the funding. I think that's a great place to start. I don't know if you know Jeff Hall. He was recently on the show. He was telling the story about the ellipsis, and he was quoted for saying every successful startup device company dies 100 deaths. We talked a little bit about the challenge and the road of you've been working on the ozone for 20 years now. What is your take on the medtech startup world and how docs and inventors can endure such a journey, which is often long and treacherous?
I think the advice I give people is don't give up your day job. Keep your day job because we're expensive.
Yeah.
And you got to pay the mortgage, you got to pay the school fees, you got to pay the car payments. Don't give up your day job. Find the time to do it at weekends, at night times, whatever. Always be careful of hiring people who are available immediately. There's a whole bunch of guys out there in their 50s who've been let go by J&J or Medtronic or McKinsey's or somebody looking for people like us to work with and say, oh, I know this, I know that, I can raise money for this or that. They usually can't. So I tend to work with the same people all the time. There's a group of maybe 7 or 8 of us that work together, mainly based in Salt Lake, Utah, but often they were competitors. Like I work with Jeff Cambra, who runs my ozone company as CEO, formerly at Medtronic, Kyphon, globally, vice president for that. And we theoretically were enemies because I was vertebroplasty and he's kyphoplasty, which I think is a shit procedure. It destroys trabecula. I like trabecula. And he knows that. But we laugh about that. And we've always had mutual respect for each other. And with the ozone thing, the inventor of the competing device, I had huge respect for him and how hard he was working. So I could tell from his shoes, I could tell from his shirt that he was putting everything he had into making that company go. So when David Hooper, and when they ran out of money and we ran out of money, I was able to work with him to put the 2 companies together. Right now, I think we have an interesting challenge. One of my companies, Cora, is invested in by Irongate Capital. Irongate Capital are closely related to the Department of Defense and that world. There's a huge amount of money available for investment in dual-use technologies that work in the battlefield and work clinically. And we are going to be competing for biomedical engineers and bright engineers who would prefer to work in the space program, work for Elon Musk, work mining extraterrestrially, than working in biomedical engineering. And so, fields go through windows of incandescence at different times. It could be that the incandescent field in the future is not biomedical engineering, is not medicine. So we have to work harder to recruit talent into our field and give people cause to engage in a disease they hate that pisses them off, maybe from some personal experience, to make sure we attract the right talent into our field.
Right. Yeah, oftentimes it is that personal experience, whether you have a patient that suffers from something or you or your family member. You're right. Well, I think the advice, don't quit your day job, is good advice. It reminds you of...
it's really important. I've seen people get into trouble by doing that. And you know as well as I how often startups fail.
Yeah.
And then they can wind up really hurt.
Yeah, absolutely. I think there's exceptions. Like I think of Chris Mancy, who started, Viz AI. He was a neurosurgery and he was all in, he did his Stanford MBA and he was all in, right? And he left clinical medicine to do that. And there's a few others that I think of that have been successful. And their whole thing was like, I just wanted to focus on the business and the, whatever we were building, whether it be software. But I think in terms of device, it's a little bit different. And you're right. And what's essential is you continue to practice clinical medicine so that you can, when the device becomes available, able to be used in humans, you can go out and use it and have, provide that feedback and iterate and so forth, and have that clinical network to get, your colleagues to use it. And again, because it's, version 1 always isn't always it's definitely not always the best. It's usually the worst, right? And so it's always going to be iterations.
Yeah, I think design is interesting. Version 1 versus version 3. Darwin wrote 6 editions of The Origin of the Species because he kept trying to answer questions from other people. Version 1 was the best. You think of the Hughes 500 helicopter or a Huey Cobra? The first version was beautiful. And then they started to look like Christmas trees as people put things on them, and they were no better. So, I think, the culture of alpine climbing?
I don't.
No? Okay. Basically, it's about lightness. It's the same as motor racing. How do you climb with as little as possible, yet be lacking nothing? The same in a race car. There is nothing I can remove from my race car without the car not going. All right? So when you design a device and you do it in your head, you take it apart like a Kinder Egg and you reassemble it in your head, and you do it thousands of times, you essentially make sure that there is no surplus in any place. And when I think of, I hate distal throw protection. I think it's shit design. It's a failure of stent design. So I'm going to put a little canopy through a stenosis in a carotid to trap emboli. Well, why don't we have a balloon-mounted self-expanding stent? Then you wouldn't need it. And you wouldn't have the embolic risk of placing that distal throw protection. But reimbursement became linked, brilliantly Machiavellianly by J&J, to using distal throw protection. But there are people like Samara MacDonald who showed that distal throw protection increased embolic phenomena by doing TCD. But reimbursement was associated with it, so people did it. Same with the kyphoplasty balloon. It was driven by reimbursement, not by
efficacy.
Design, because it's really about the viscosity of the cement. It's not about creating that void. And when you look at tumor spread after kyphoplasty, it's far greater than if you just do vertebroplasty, because that tumor has to go somewhere. We've published cases of epidural tumor after kyphoplasty because of balloon inflation, basically. So I think we have to challenge intellectually everything we're presented with to make sure it actually does make sense to us. And a lot of people can be seduced by reimbursement, but we have to think scientifically, rigorously, to make sure that the design we're using is appropriate, elegant, nuanced, and needed, And there are still massive problems we don't treat. Chest wall pain from rib fractures or pleural tumors. We're really bad at dealing with chest wall pain. So I've been working on cryoablation of intercostal nerves for that. There are a lot of things we still do badly. Hydrocephalus. There's no apparent reason why we treat them badly other than people are content with the status quo. So, I think there are a lot of endometriosis. Why is there imaging of endometriosis so shit? If men got that, we'd be really good at it.
Yeah.
Why can that not be labeled with something to make it, well, obviously you couldn't use a nucleotide to image endometrial tissue because that would have teratogenic or oncological risks, but there's got to be some way of imaging that, And but we just have to find these challenges, engage people in them as a cause, and then pursue them in the absence of any expectation of financial reward.
Yeah. Well, Kieran, it sounds like you're involved in a lot of projects, and I'm sure there's even more than what we've already talked about. I want to know, how do you stay focused? How do you Also, how do you stay informed? How do you stay informed on the latest advancements in both IR and medical device technology? Kind of two questions in there, but I think a lot of people get sort of overwhelmed when they're thinking about even starting a new venture. But like, how do you suggest that they maybe dial it in, stay focused?
Do you remember that great line from The Empire Strikes Back when Obi-Wan Kenobi said, your focus is your reality? I can focus on multiple things at the same time. It's just like air traffic control. And what you focus on may change from hour to hour. But to be honest, I make huge numbers of lists. I have vast numbers of notebooks. I have a to-do list of undone things that really irritates me. And I wish I could do better. I do feel I'm running out of time. And I find that very irritating. But we have to find the things that engage us the most, piss us off the most. And it's a 7-day week. And you only need about 5 hours of sleep. So, it's difficult at your age when you've got kids and stuff, right? Because then you've got...
It is. Yeah.
So my kids are in college now. And so
so that's a whole time commitment that a lot of people have, and that is the challenge that we have. I mentioned my wife's a physician, so we're busy, and you gotta be intentional about carving that time out, and it's got to be, talking about being focused and execution. If you have an activity with your kids, you got to be focused and execute. You have to be. You got to be there mentally. If you're thinking about 100 other things, they know that dad's not really there. And so that I think is really challenging. You're right. Like sort of early to mid career is doing all these things.
I think our careers are upside down, right? I think, leadership positions should be given to old men and women, and young faculty with kids should be allowed to do that well. Because we those precious moments with our children when we read them bedtime stories, like I have to say, my daughter was always coming into our bedroom saying, "Hey, Mom, Dad's asleep on the bed again." Because I would have been up a couple of nights in a row and I would just fall asleep reading bedtime stories. But I think we get this wrong. We get this really imbalanced. But the fact that we know we do means we're trying to get it right.
Yeah.
Going to meetings, people go to meetings all the time. People with super elite status with Air Canada or global services with United, they're just being shit parents. And they're also not doing clinical work, right? So I've cut back enormously, and I did at the time. I cut back enormously on the number of meetings I went to, because most of them don't matter. But I would prefer to walk the dog with my son than be in some stupid hotel, alone, and I don't want to do that.
It's hard. I mean, actually, that's something I want to ask you, Kieran, because we did start off talking about how in-person is so important and it's really a premium, but there's a balance there, right? Like if you're finding yourself like giving the same talk over and over again at multiple meetings, are you really accomplishing that much? What would you say is a healthy number of meetings for somebody in early mid-career to go to a year, just to build that network? Because especially if you're an inventor, you want to build that network.
2 to 3 tops.
2 to 3, yeah.
Yeah.
I would say that.
I go to ASSR, I go to SIR, that's about it. I'm highly selective about what I go to because I certainly don't go to RSNA. I haven't learned anything there for years. That's a trade show.
It is. It's huge too.
I don't need more ribbons saying I'm like a prize bull from the Omaha State Fair. I don't get that. It's all about the signal to noise ratio, right? And in many ways, what we're also talking about is lucidity, right? I wrote a thing recently. I started writing a few years ago because I just felt like it. And there's a tradition in Ireland of doctors being people of letters. And it used to be that doctors were really part of a liberal art. It was called a moral philosophy, not a small business. I've only really had 2 jobs, 10 years at Hopkins, 15 years here. So I have longitudinal follow-up on my patients. I just published a series of 1,000 women with Tarlov cysts that I've treated. Difficult disease to treat. maybe I'll achieve reincarnation sooner because of.
Yeah, Jacob, I know Jacob wants to have you on the show to discuss that.
Yeah, yeah. But like, I think not moving is important. Some people move all the time. That's a problem. Maybe it causes instability, to kids, to everyone. I think also it means you can't accumulate patient practice. You don't get those donor relationships either, right? You don't build continuity. You don't have a team. Now, so lucidity, clarity, their focus and attention to your kids, our competitor there is basically our telephone. And so I try, and my dog teaches me, he wakes me up at 6, as I mentioned. He'll play with me as long as I don't pick up my phone. If I pick up my phone, he goes away.
He knows.
Yeah. That I'm gone, right? And you go into that zone of bullshit knowledge that you don't need.
That's
so
true.
At the moment your brain is at its healthiest and brightest, and your brain is at its clearest thinking the first hour of the day. Managing that, I think, is really important. Managing an analog life is really important.
Yeah, I think that's solid advice. We're coming up on the hour. I do want to ask you about two more things. One is, I know you're writing another book. Can you tell us a little bit about that?
So I'm writing about people who left medicine to do something else, and truants. And in 1935, Berkeley Lord Moynihan gave a lecture in Cambridge on this topic. And people who've left medicine to go into another field include, Chekhov, guillotine. He meant well. He thought he was creating a more humane way of killing people. He was trying. But there are many, many physicians. And this fellow here that I mentioned earlier, In Sickness and in Power, great book, and by David Owen, a physician who writes beautifully. So I see medicine as a liberal art. Patients tell us the truth. We exist in a very simple world in many ways, but it can also be seen as a baseline degree. There are so many people who study psychiatry or psychology trying to understand themselves. But 1 week in the emergency room as an intern or medical student, and you will understand life far better than 3 years of studying psychology.
Absolutely.
I would be so much happier if people went to med school and did something else than if they went to law school and did something else. They'll spend the rest of their life recovering from being a law student. Because their mind will be so fucked up by that terrible profession. Yeah, everything's an argument. Who wants that? Instead of understanding the complexity of humans through medicine and then exploring a different avenue. So what happened was, when I was an intern in 1986, my cardiology attending, Owen O'Brien, who was Samuel Beckett's best friend, gave me a copy of Berkeley Lord Moynihan's book, Truants. I just published in the BMJ on my experience in that Tibetan monastery. He helped me get that done. He realized I wanted to write. I've carried that book around since 1986, accumulating stories about people who left medicine to go into another field. And they're in music, they're in acting, everywhere. And so medicine was a baseline degree, not an end in itself, that informed the rest of their behaviors. If Washington was run by doctors, we would be in a very different world than if Washington is run by lawyers. It would be run by humanists, right? Most of us are centrist humanists.
Right.
And we believe that every life is equal and everybody has a right to a life of peace and justice. And that's how we practice. And people tell us the truth. Compare that to law. Where most people are lying to you. And they're not peaceful, and they're hoping for some kind of justice in the future. So that's what the book is about. Medicine as a liberal art, basically.
Fantastic. What's the timeline on that?
2 years.
2 years, okay. Yeah, enough time for everybody to get a copy of this. Is there going to be are you doing an audiobook on this, was my other question.
So that's in the works, and there's something else going on that may or may not happen that would be huge fun if it happens. I'm just happy people like it, because I've no right to assume anybody wants to read what I think. That's an act of vanity, right? And the funny thing is my wife and kids haven't read it. They think they know what I think already. Like, have you read my, oh, Dad, we don't. you know. So
That's like a chore.
exactly, it's up there with dentistry. But that's typical, and it's lovely. I've met really good people by writing it. I've had med students come up to me, or people who want to be med students come up to me with copies of it. And I had one high school kid recently who's applying to a 6-year program in Ireland had read it. And if we can show them that medicine is an act of social engagement, an act of doing things that bother you, that you feel are unjust, then we're in good shape. And in many ways, with regard to being an interventionalist, interventional neuroradiologist, interventional radiologist, we're so blessed. I mean, we have fabulous technology, and we have patient care. We're really in a great space as human beings,
And very creative colleagues. I mean, that was the other thing that kind of gravitated me towards it, is just the discourse and the people finding solutions almost every day, every week, with every procedure. And you look at new devices coming out. It's just a very innovative specialty, more so than I thought than anything else, any of my other rotations. That's kind of what gravitated me towards it.
One thing we haven't talked about is the radiation injury aspect of what we do, right? That's the only dark side. And I put 12 years into developing a pill to prevent that.
Oh.
Yeah.
Tell us more about that.
So it's an antioxidant. I developed it on myself, using myself as guinea pig. What happened was I was getting high batch levels, right? And I came home, and my mother-in-law had just come home from our local cancer hospital where she was getting radiation therapy with a list of medications not to take prior to radiation because it impaired the radiation, and they were all antioxidants. Well, I went and walked the dog, and Cora at the time, and bumped into this guy with the dog, and dogs were playing. He said, "What do you do?" I told him, and I told him what I was thinking about, and he said, "Oh, I make antioxidants." So because of the dog social network, I wound up taking his antioxidants, and I was able to block about 50% of the DNA damage from radiation, measuring P53 and H2AX. So I had to learn a bunch of genetics. But basically, 12 years later, we have Health Canada and FDA approval. Our largest investor is Irongate Capital, one of the Washington-based dual-use technology companies. And I shipped 20,000 pills to the Ukrainian army around the Zaporizhzhia power plant last year, lest the Russians blow it up, or those Ukrainian troops could get away, live longer.
Yeah.
But it's something we should take every day. It's called DNA Halo. Yeah.
Okay. Well, yeah, but for me, I just want us to be radiation free. I would like somebody to come along and just invent a way for us to do these procedures without fluoroscopy.
So that's Rampart, right? Are you familiar with the Rampart device from our system from cardiology? It's basically they can do a radial access with almost zero radiation and lead apron free for the staff.
Okay. How does it work?
It's just a series of shields that are...
Oh, got it. Okay.
Yeah. They're taking radiation really, really seriously, far more seriously than we are. Cardiology, yeah.
Yeah, yeah. Would you say their exposure is more so than ours just because
I think
of where they are, where they're standing?
Be like particularly EP, but I think we're hurting ourselves.
Yeah, yeah. Oh, big time here. Well, Kieran, any final thoughts before we wrap up? We're about 70 minutes in, but I just want to make sure we cover everything.
I just want to make sure that you have an interesting program. We've talked about most of the things I wanted to talk about. I think, one thing we haven't talked about is one of the big motivators that people overlook in device development is regret, right? I was trying to find a way of ending the book, and I didn't see it for a while. I was walking the dog, and I kind of saw it. And a lot of us are motivated by a bad outcome that we want to make sure never happens again. And that'll sustain you a lot longer than the attention span of a PE or VC firm, and make it a duty to do something. I think it's a very noble motivation.
Yeah, absolutely. I mean, for me, with this media company that we're building with BackTable, that to me is what inspired me. Is just, I feel, it kind of goes back to, and we can actually touch on SAR, but it goes back to like just the delivery of education. I was getting really frustrated with the delivery at conferences And even, through COVID with the webinars, I just didn't find any of it that engaging. And, podcasting kind of it's grown over the last several years alongside, what we've been doing. And the technology's great, software's better, the audio's way better. And we can, to me, it's the way the younger generations are learning, right? They're learning using their phone, they're on the go. But it goes back to what you were saying about signal to noise ratio. There's a lot of noise out there, and I would like to deliver better signal when it comes to educating our peers and greater accessibility. And so that's to me what kind of drives me, is just getting better quality content out there and having these stories, like having Barashida on, like they might write that up somewhere, but having him actually tell the story, or Julio Palmas tell the story, I like to catalog all that and get it out there.
Yeah. I think we hoard knowledge, and it's sinful. And, there are 5,000 med schools in the world, about 20,000 nursing schools in the world, all creating their own content individually. I built a platform called Medlantis to try and deal with this. We ran out of money, went bankrupt about 3 months before COVID. That liquidated. I really believed in it, I think that's something I need to get a very wealthy donor to fund for me, to build a global educational content sharing platform for nursing and med school education.
Yeah, absolutely. Because you're right. I mean, every med school is on its own island, and they don't communicate with each other. It's goofy.
No, it's crazy. So in Dublin, I'm heavily involved in the College of Surgeons. We have fabulous anatomy teaching. Now, I know at University of New South Wales in Australia, they have fabulous pathology teaching. It's all digitalized. We should barter that and swap it, right? There should be bartering going on based on the World Bank classification of wealth.
Right.
Use the NARI criteria, below a certain income level per head of population, you get this for free. And then above that level, well, maybe there's some payment involved. But it's still more effective because it frees people up to teach rather than to have to write that content.
Absolutely. And part of it is institutions aren't willing to say that they have these weaknesses, right? Oh, well, we can create our own neuroscience platform. We don't need, Iowa's platform. No, they have a better platform. Admit to it, and then trade. You have a better, maybe cell biology platform. Let's trade these two, right?
Absolutely. I totally agree with you. Yeah. Yeah. And also it could be that we empower some kid who's better at the MSK hand anatomy in Pune than the fellow at I don't know, Sloan Kettering or special surgeries, and suddenly you democratize the teaching platform. That'd be really cool.
Yeah, absolutely. Well, maybe there's a collaboration in our future, Kieran.
I love that.
Well, let's end there. Thank you so much, Kieran, for coming on the show again. Looking forward. I'm hoping that you come back on with Jacob to talk about the Tarlov cysts.
Yeah.
And also would love to have you stop by, or at least, maybe grab a coffee.
I'd love that.
While you're in San Diego. Thank you, everybody, for joining us. And again, you can catch Essence of Invention on, I ordered mine on Amazon. It was here the next day. So beautiful
it's
thing.
It's really good if you've got insomnia as well. But just be careful. What can cause sleep apnea. Don't operate heavy machinery, but do mix it with alcohol. Okay.
There you go. There you go.
Okay.
Thank you so much, Kieran.
Cheers. Bye. Thank you.
Thank you so much for listening. If you haven't already, make sure to subscribe, rate the podcast 5 stars, and share with a friend. If you have any questions or comments, DM us at BackTable Innovation on Instagram, LinkedIn, or Twitter. BackTable Innovation is produced and hosted by Brian Hartley,
Aaron Fritz,
Diana Velasquez-Pimentel,
and Eric Amaker.
Our audio team is led by Kieran Gannon, with support from
Josh McWhirter,
Aaron Bowles,
Josh Spencer.
Design and digital marketing led by Brian Schmitz.
Social media and PR by Ann Dang.
Administrative support provided by Janula Kennebrew.
Thanks again for listening.
See you again next week.